With the patient in dorsal recumbency, the transducer in a ventral midline sagittal position and depth adjusted so that the liver fills the screen from top to bottom, the normal liver will fill about half of the ultrasound screen from left or cranial to right or caudal. This general guideline only applies to patients in dorsal recumbency with the transducer in the ventral midline sagittal position. The liver should also not extend ventrally over or beyond the stomach. The cranial liver is normally curved to follow the diaphragm. The ventral liver capsule is a smooth, hyperechoic line. The ventral and caudal liver edges are sharply pointed or angular, especially at the ventral stomach wall. Normal liver has a homogeneous tissue density with an echogenicity similar to normal falciform fat seen at the ventral midline sagittal position. Homogeneous liver parenchyma is interrupted by hepatic blood vessels, which will be described later. Normal liver is usually isoechoic to normal cortex of the kidneys. Note the mild diffusion between the caudate liver lobe and cranial pole of the right kidney in this right lateral sagittal view of a dog with a ruptured splenic tumor. Normal liver is usually less echogenic than normal parenchyma of the spleen. Color flow Doppler is very helpful in identifying and locating blood vessels. Color flow Doppler shows direction of blood flow. The ultrasound beam originates from the transducer and is depicted as originating from the top of the ultrasound screen. The standard color flow map uses the BART system, where movement away from the transducer or down is shown as blue, and movement towards the transducer or up is shown as red. BART, blue away, red towards. The color flow Doppler icon is at the top left side of the ultrasound screen in the sagittal view of an extrahepatic portal vein of a cat. The icon shows red as up or toward the transducer and blue as down or away from the transducer. Intrahepatic portal veins have hyperechoic or bright white walls and carry blood from the intestines into the liver in this transverse view. Homogeneous appearance of the liver parenchyma is interrupted by hepatic blood vessels. Approximately 75% of the blood supply to the liver comes from the intrahepatic portal veins. In this transverse view, the portal vein branches right and left to supply the separate liver lobes. The intrahepatic portal veins are red with color flow Doppler because blood flow is upward or towards the transducer. The intrahepatic portal vein should not connect directly to hepatic veins or to the caudal vena cava. Hepatic arteries are usually too small to see in the liver. In a ventral sagittal view, the extrahepatic portal vein enters the liver at the porta hepatis. This vein drains the intestines. The splenic vein joins the extrahepatic portal vein just before it enters the liver. In this ventral sagittal view, hepatic veins drain blood from the liver to the caudal vena cava, which is dorsal to the liver. Hepatic veins do not appear to have walls on ultrasound and will appear blue with color flow Doppler because flow is moving downward or away from the transducer. Hepatic veins should not directly connect to the intrahepatic portal veins. Color flow Doppler shows direction of blood flow in vessels. By adjusting scale, it can also give an idea of flow velocity. Color flow Doppler requires a tremendous amount of computer capacity and tends to slow the frame rate of the video image. In most small ultrasound machines, color flow does not work well at deep depths. Power Doppler shows the presence of blood flow in vessels by a yellow or orange color. It does not show direction or velocity of blood flow. It tends to be more sensitive to flow and does not slow the frame rate of the video image as much because it uses less computer capacity than color flow Doppler. Power Doppler can be used to get a better idea of blood flow to tumors or to differentiate blood vessels from bile ducts in the liver. Power Doppler can be used at deeper depths. In general, all normal appearances for dogs also apply to cats. However, cats can also store fat in the liver just as they store fat in the tubules of the renal cortex. So, a hyperechoic liver parenchyma in an older obese cat with no symptoms could be normal. In this video, note the thickness of the falciform fat in this 24-pound cat. Also note that the liver is hyperechoic compared to the fat. When imaging the liver and gallbladder in the abdomen, it is common to see what appears to be liver and gallbladder on the thoracic side of the diaphragm. What we are calling the diaphragm is actually an interface between a fluid density, the actual hypoechoic diaphragm muscle, and a gas density, air in the lungs. In the Tips and Techniques DVD, we learn that gas strongly reflects the ultrasound beam. When imaging the liver and gallbladder, the ultrasound beam passes through and creates an image of the liver and gallbladder. Then the rest of the beam is strongly and completely reflected from the gas interface at the diaphragm and passes back through the same tissue in reverse order. Because of the time delay, the ultrasound machine assumes these reflections come from the other side of the diaphragm. The curve of the diaphragm also causes some refraction of the return. It is important to recognize mirror image artifact. Do not automatically dismiss everything on the thoracic side of the diaphragm as mirror image. The heart, thoracic masses, or pleural effusions in direct contact with the diaphragm will also be seen. Adjusting depth to fill the ultrasound screen with liver helps reduce the mirror image artifact. Placing the diaphragm to the left side of the ultrasound screen also reduces this artifact. In this video, liver dorsal to the gallbladder appears hyperechoic compared to liver ventral to the gallbladder. When we fan away from the gallbladder, the liver appears normal and homogeneous. Through enhancement artifact results from a lack of attenuation of the ultrasound beam as it passes through an anechoic structure like the gallbladder. There are no standard measurements for liver size in dogs or cats. Lesions can be measured by length and width for comparison purposes for future repeat examinations in the same patient.